Okay, we have a few minutes to present the association of Angio-CT and why we are using it. I think the high-end interventional in oncology, particularly today, are becoming more and more complex. Having a room like this, having an angio, having a CT, having an ultrasound in the room, for difficult cases becoming something very frequent, and you can push the boundaries when you have something like this. Means at the moment you are putting the patient in a room like this, you have already planned what I will use. Mostly CT, mostly angio, mostly ultrasound. We are planning the patient when we see them on the consultation. We have 3 operating room, 1 con beam in the side. We have 1 Angio-CT and 1 MR. So when you see the patient, you have to decide in which room you want to operate your patients, and you can do it. We began with 1 Angio-CT, and now we have 2 large hospitals. We have in each of them another Angio-CT, because the hospital has understood and all surgeons have understood why it's an asset for the hospital to have both of them at the same time. If you look at the workflow in the room, it's very easy. You can begin like here, with the angio part. That's why in the majority of cases when we are doing liver or kidney today, we are always nearly every central tumor, every difficult tumor, we begin with the positioning of a catheter. It's taking 10 to 15 minutes. I'm sure for Dr. Ara even less. I have seen him working in 10 minutes in and out. So when you have put the catheters in, at this moment you can inject a little bit of contrast every time and having the whole volume of liver or kidney in 0.3 seconds. That makes your life a lot more easier than before. Here we are. Let me change the slide. You have seen enough of this. If I can. Here we are. Let's change. Okay. Next. Let's click here. It's easier than I think. Here we are. So at this moment, you are at the possibility to choose the volume you want. From 2 centimeters to 16 centimeters acquisition, the machine can make a fusion between angio and CT. You can use it as a mask and bring it to the other side. You will tell what you want to embolize. It will show you exactly which vessel you have forgotten, which one is feeding the tumor without forgetting to embolization. And you see for a case like this, that's a patient we are following up. The Mets is visible in MR here in front. No, this is not changing the slides. I'm not in the right slides. Next one. Let me see. Yeah, here we are. Let me see. That's it. You have a liver case like this. On MR, you see the Mets. To see exactly where you want to go, here we are. I think there is something not, what I see here is not what I see there. It's okay. I will show you like this. Here we are. Anyway, you see with 15 mils of contrast, you see exactly where is the Mets. 15 mils, 0.3 second acquisition, you see your Mets. Here it is. You plan with a CT scan and your cone beam if you want exactly where you want to go. The system will show you the pathway of your needle, avoiding the lung. You get there. When you have done, you do again 15 minutes of contrast to confirm that you are near the Mets. And when you have done it, you do the ablation. At the end of ablation, again, 15 minutes of contrast, another acquisition, and you confirm if your ablation has been complete or not. You have noticed at the same time we have protected the diaphragm, because every time you can protect the organs adjacent, do it. Diaphragm perforation is painful. In the right side, it will not be an herniation, but in the left side, every time you destroy the diaphragm, is a high risk of herniation. The hydrodissection, very easily done. As we said, you can, at the moment you hydrodissect, go to fluoroscopy to see the diffusion of your product, if it's right or not. Here we are, another case. That's a recent case I have done last week. That's a patient I like a lot. That's 10 years I'm following her for a neuroendocrine Mets of the colon. Many ablations done, and she comes back with this new lesion now and having a huge Mets nearly the biliary tree. It means I cannot do thermal ablation. In this case, again, we begin with angio to see where we are. So I have my angio suite. I do my arterial injection, 15 mils, and look at the Mets. I think you cannot miss it here. Huh? Because I cannot do thermal, for the large Mets in front, we are planning to do an IRE. So we position 6 electrodes all around. The problem of IRE here is, it's okay, but I will not obtain the margin I want. You see what I mean? This is not the margin you want to obtain. In this case, I need to add it. As you know, we know now that when you do IRE, you have always around the irreversible a quite large zone of reversible. Means this part of reversible, I can use it to increase my margin by associating bleomycin, like what we do in best cases in malformation or the other, reversible electroporation, electrochemo. In this case, before doing my electroporation, 8 minutes before I inject my bleomycin, it's just 12 milligram. The dose is less, and all these patients are under general anesthesia and jet ventilation. So the patient is not moving, patient is sleeping. At this moment, we have done our electroporation, a second one pulling back, and I have associated the irreversible to reversible to have large margin. The Met, which is above, this one is okay, it is not in danger. This one is done with microwave. And as you can see, end procedures, immediately no complication. And the day after, you see how large can be your ablation. And I'm sure in 3 months, when I will control it because of the BEST and electrochemo, it will be a lot larger than what we have seen here. Anyway, for renal cryo now. Again, for renal cryo, we learned for central tumors systematically doing it with angio, putting the renal catheters inside, radial approach or femoral approach, and closing the heating system of renal artery during the ablation. Means you put a balloon in renal artery, because you can see that's a really central tumor. We have enough gas now. We have 4 tanks of 700 liters, so we will not miss it. We see a lot of needles, hydrodissection of the cavity. The junction is protected, so the kidney, all the surrounding is protected by hydrodissection. Looks a little bit like a gas factory, I know, but that's it. Number your cryoprobes to know what you are doing. And at this moment, you have already the catheter in renal artery because you have the Angio-CT. And when you want to do the cryo, you close the tab. The heating system is closed for 10 minutes. 10 minutes is nothing for the kidney, okay? So you don't have the cold sink effect during this time without embolization, without sacrificing the nephron system. And look at the ablation. They wanted us to do a heminephrectomy, and here you are. You have the heminephrectomy done at the cryo without doing it. All these tumors now today are done the same way. When they are central, use the catheter, close the tab, and you are not losing any renal function. Last example, that's a kid, ganglioneuroma, 8 years old, huge tumor of the pelvis, compressing the ureter, the colon, the bladder. These kids should go every 10 minutes to the toilet. The bladder is completely compressed and ureter is there. Percutaneously, we cannot do it. I think you agree. I will not play with this tumor here. So what we have done, first step, monitoring. And when we are very near the sciatic nerve, and one of the complaints of the girl is sciatic pain. So I need to monitor the patient. Electrophysiology is the first step. In France, we have big difficulty to get neuromonitoring. So 2 guys of my team learned how to do it. Finally, we are very good because with ultrasound, you can find the muscle easily. Not difficult to learn, but we bought the machine ourselves. We have our own neuromonitoring. All these patients, again, are general anesthesia. So now what we do is we call our surgeons, because the room is installed in a ISO 5, means you can do surgery inside. Our colleagues and friends coming to the room to make a mini lab for us. So we are very happy to work with them. And the lucky thing is the urologist is my best friend, so it's very helpful to have good friends in surgery. They come and, they begin to dissect. They find the ureter first. They isolate the ureter. Then they pushed away all bubbles. They pushed away the bladder. So I have direct access to the tumor directly through this. Once they are ready, as you can see here, they begin and we put a double ring. That's a plastic double ring, which allow you to have no artifact on CT scan, and they open up the space for you. So you can get directly access to the tumor like this. You see, that's easily done. That's the interesting part of the intervention, because at this step, when they do this, there are 10 people around in the room to watch. And then the next step, when you do cryo, you are alone. I mean, this is it, Life is done. Surgeons have always looked a lot sexier than us. I don't know why, but we do the same job. I wash and shower every morning, but this is it, And here you are, at this moment, they open up and they leave the room. You are alone and you are beginning, and now they put all the gas to remove everything. So you have a direct access to the tumor like this. They take their time. All this part take about 45 minutes. For them, is quite fast, and they like to work with us. Here we are. I have the tumor. I do my CT scan at this moment. You have the gas, and what I have seen is that the rectum they cannot go so deep in the pelvis, is still in contact with the tumor. So I need to add a hydrodissection of the rectum with, HydroGuard, quickly again went there, and you can see behind you have still the rectum coming in contact with the tumor. That will be dangerous to freeze. So all cryoprobes are in position, hydrodissection is done, as you can see, and then you begin to freeze. Here you are, everything controlled. The CT scan, very important in this phase because you can be fast. 0.3 second SCT, a volume. And then here we are, freezing time. As I said, at this moment, you are alone. Eventually, one of the nurses is kind enough to stay with you. That's all you do. And then you wait. And then in the CT scan, again, you control your ice ball. Once done, 6 months later, look at the shrinkage of the tumor. She is doing a lot better. It's not healing. The tumor is still there, but we have really shrunk the tumor. And look at this, before in the left side, 6 months later, a very nice recovery. And she has no pain in the leg. Anyway, as you can see, association of both is useful. And I'm not forgetting the ultrasound. All this system for complex cases open up a new windows for complex interventions and bringing all specialists around the patient. Anesthesiologists for sure, surgeon can come in, neuromonitoring is coming in. For difficult case, we put the patient in the mid, you have all setting and you can really push the boundaries really comfortably because anytime you need angio, you come to angio. You want to go back to CT, you come to CT. And one thing I can tell you, for difficult ablation of liver and kidney, putting a catheter in make your life a lot easier. And you inject just a little bit of contrast, not much. Thank you very much for your attention.
Well, thank you, Afshin. That's so nice lectures. So is there any questions or comments? Too exciting presentation, also because of that, and we cannot have it. You have questions? Okay. The Yamakado, do you have? Okay.
Yeah. Don't trust them, they are friends.
No, please. Oh. Please use the microphone, please.
The question was how long it takes me to do the case. The kid. You block the room for 4 hours. I know that's expensive, but that's exceptional cases. And every time, as I said, when you see the patient on consultation, we have a form. You have to say which room you're operating on, which specialist you need, what materials you need, and how long you want the room. That's important. Again, all these rooms are dedicated for interventional.
So mostly with these kids, right? When we do cryo on adults, it's different versus kids. So what is your protocol? Do you do 10-8-10? Do you do 3-5? I mean, what is the protocol for the kids, for pediatrics, when you got big cases like this?
Yeah.
Or number two, do you say, I got a big case like this, complexity, should I do half of the case now, bring the kid back in a few weeks, scan, see how the kid looks, and then proceed?
I try to do it in one session every time I can. That's it. So I do one general anesthesia and I block the room as much as I want. That's the advantages we have. That's nobody is asking us how much we are using the room. We have done a contract with the hospital that we are shortening the hospitalization of the patient and they don't control us much. But again, sure, that's a very expensive case. We cannot do it every day because, as you have seen, we have blocked 2 teams, 1 surgical team, 1 interventional room, and for 4 to 5 hours. But I try to do it in one session if I can. If it's dangerous for some tumor, I cannot hydrodissect. I do a part first and I take the patient second time, a few months later. Thank you.